So a quick review on the patellofemoral joint. So what is the patellofemoral joint? Basically, it's just the femur and the patella that make up the patellofemoral joint. So this is a common cause of knee pain in the clinic, typically referred to as patellofemoral joint syndrome or pain syndrome. Basically, it's an umbrella term for any type of knee pain related to the patella. The most common cause is typically maltracking, which causes abnormal pressure on areas of the undersurface of the patella that should not have these pressures. So common muscles involved in this are the quadriceps, which are the femoral nerve, glute max, glute medius, and glute minimus. Many studies, or several studies, have shown that hip abductor weakness has been related to patellar maltracking and patellofemoral joint pain syndrome, and several studies show glute strengthening has improved the knee pain. The Q angle is something that people may ask you about. So what that is just a line from the ASIS through the midline of the patella, and then the tibial tuberosity, a line from that through the midpoint of the patella, and basically this angle right here is your Q angle. There are some studies that show Q angle is not related to patellofemoral joint pain or pain syndrome, but it's still good to know that. So normal is 10 to 13 in men and 15 to 17 in women. That's just because women have wider hips for childbearing. And then this would be a merchant or sunrise view. So this is lateral, this is medial. If you're ever looking at an x-ray and you're not sure which side is which, the lateral side is typically larger because it helps prevent lateral patellar dislocations. So the patella should glide nice and smoothly within this trochlear groove. If there's dynamic or static instability, then you're going to get either a pull to the medial side or lateral side, and then that will cause pressure on the undersurface of the patella, which the patient will start presenting as pain. So common ones, typically the most common cause are the dynamic stabilizers that are either tight or not strong enough. So keeping the patella within that trochlear groove, you're going to have static or dynamic stabilizers. Static ones are ones that are ligaments, the trochlear groove itself, the patellar size, bony, things like that. The dynamic ones are going to be muscles. Those are the ones that we have most control over, that we can alter. So if something is pulling the patella laterally, then typically either structures on the lateral side are very tight, or the dynamic stabilizers on the medial side are not strong enough to counteract the lateral force, but typically it's due to tightness. So things on the lateral side, based off anatomy, are going to be your IT band, the vastus medialis. And then for the medial side, your BMO is very important, how it pulls the patellar medially. Another important thing to consider, which sometimes is overlooked, is hamstring tightness with patellofemoral joint pain syndrome. Why is that? Because the hamstrings perform knee flexion. So if you're trying to extend the knee as someone who's exercising, doing squats or a leg extension, and they start complaining of knee pain, the tighter the hamstrings are, the more force the quadriceps have to generate to overcome that tight hamstring, because that tight hamstring is trying to keep that knee in flexion. So to perform extension, these muscles have to overpower these muscles. So if this is really tight, these are firing more and could push that patella down against the femur as it's trying to extend the knee. So it's also important to check out tight hamstrings for patellofemoral joint pain syndrome. So another important thing you could get asked when you're on rotations or clinically, it's also useful to evaluate the knee as well, is the patellar position. So a high patella will be alta and a low one will be baja. And to evaluate if they have a high riding or low riding patella, which could increase contact pressures upon the posterior aspect of the patella, you'll take an x-ray typically. There's also a way of looking at it with MRI, but x-ray is much cheaper and quicker. So you're going to look at the superior pole of the patella and the inferior pole of the patella. That will be B. And then from the inferior pole of the patella to the tibial tuberosity where it attaches will be A. And then A over B will give you your insol Salvetti ratio. If this number is less than 0.8, then it's a Baja patella. If it's greater than 1.2, you have patella alta. That could also be a board topic for PM1R boards, so it's important to know. So the patient comes in with what you think is patellofemoral joint pain syndrome. What can you recommend? So obviously you're going to recommend physical therapy to help strengthen weak muscles and stretch tight ones. But in the meantime, you can recommend some exercises besides just writing an order. So some useful things. We want to stretch the things that are tight. So you want to evaluate the knee, see how they're tracking. You want to typically stretch lateral structures. Those are the ones that are typically tight. So how can we do that? So we want to focus on the vastus lateralis and the IT band. So two easy stretches they can recommend at home, you can recommend at home, is the quadricep stretch, but with a focus on the lateral aspects of the vastus lateralis. So just a normal quadricep stretch, adding in hip adduction, and this hits a lot of these lateral structures here, just like that. And then if you want to hit the IT band does internal rotation and adduction, as well as helps with knee extension. On the involved side, you just do hip adduction to where the patient feels it along their IT band, just like that. Those are two simple stretches you can recommend. Then to strengthen the muscles that are affected, so typically it's eccentric exercises that aggravate patellofemoral joint pain and tendonitis, similar to lateral epicondylitis of the elbow. So you want to focus on eccentric exercises. So we want to focus on that. So they can stand on a surface, a curve, a step, and they slowly come down. So working on that quadricep, eccentric contraction, and then back up. Make sure the weight is not on the balls of the feet. That puts a lot of stress on the patellofemoral joint. The weight should be through the heels. They should be able to lift their heels off the ground if they wanted to, and then progress to taller structures. They can use support such as PVC pipe, just like that. So that is to work on the eccentric portion of the quadricep muscles, and then very important to work on the hip abductors. So simple one, obviously the hips do abduction, so they can lay on a ground on the surface, or so they can lay on a table or a bed or the floor, and then bring the hips up. However, a better or another really good exercise is to have them stand on one leg. So if we're going to be working the left hip abductors, then we want to stand on the left and actually move the contralateral extremity. So even though I'm actually doing abduction with my right hip, so it is working my hip abductors, the left one's actually going to be working quite a bit more. And you can do other motions as well. You can have them spelled the alphabet. So A, B, C, D. You see if someone can do that without rest, or 3 sets without rest, or whatever you want to recommend. Why is that? Because the leg that is standing on the ground, not performing the action, has to stabilize the pelvis and keep that pelvis neutral. Remember, if the pelvis drops, what do we call that? During the gait cycle, we call that a Trendelenburg Gate. And why do people get Trendelenburg gaits? Because they have hip abductor weakness. So that is why standing on that leg will actually work that hip abductor quite a bit more than the leg that is moving. So most people think the leg that is moving is the one we're focusing on, where actually it's the leg that we're standing on. So those are some simple ways that you can help your patients before they get into a formal physical therapy program for patellofemoral joint pain syndrome.